Hello, and welcome to the Asthma and Allergy Foundation of America's latest education program titled Life with Eosinophilic Esophagitis. Today's program is developed independently by AAFA and made possible by support from Sanofi and Regeneron. We're all so glad you are here. My name is Stacy, and I am the Public Health Manager here at AAFA. You will also meet my colleagues and our speakers here in just a moment. But first, I would like to tell you a little bit more about AAFA and who we are. The Asthma and Allergy Foundation aims to be a trusted ally of the asthma and allergy communities. We are dedicated to saving lives and reducing the burden of these diseases through support, advocacy, education, and research. Without you, our community, we wouldn't be here. So thank you for everything you do for those everywhere with asthma and allergies. Again, I'm Stacy, and I'm so happy to be your host for the program today. Your speaker, who you will meet in just a moment, is Dr. Evan Dellon, and we are also joined by Mary Jo Strobel, the Executive Director of the American Partnership for Eosinophilic Disorders. And finally, we do have someone on the back end assisting and making sure everything runs smoothly. Her name is Zulima, and she is our Support Center Manager. So today we will be discussing eosinophilic esophagitis. Dr. Dellon will take us through the symptoms and talk about many of the challenging reasons it might be difficult to diagnose. We will discuss management of EOE and talk about the different kinds of treatments available. We will also give some pointers on how to work with your doctor in developing a treatment plan. And then finally, our guest speaker, Mary Jo Strobel, will jump in and talk with us a little bit more about community support and resources at APFED and also at AAFA. Hi, everyone. How are you doing today? Great to have you all here. So our speaker today is Evan Dellon, MD, MPH. Dr. Dellon is a professor of medicine and an adjunct professor of epidemiology at the University of North Carolina School of Medicine in Chapel Hill. Dr. Dellon received his undergraduate degree from Brown University and his medical degree from Johns Hopkins School of Medicine. He completed an internship and residency in internal medicine at Massachusetts General, and Dr. Dellon performed a clinical and research fellowship in adult gastroenterology at UNC and received a Master of Public Health degree in epidemiology from UNC School of Public Health. His main research interest is in the epidemiology, pathogenesis, diagnosis, treatment, and outcomes of eosinophilic esophagitis, or EOE, and eosinophilic GI diseases. The goal of his research is to improve the lives of patients with EOE and EGIDs by learning how to better diagnose, treat, and monitor these conditions. Dellon is currently the director of the UNC Center for Esophageal Diseases and Swallowing and serves as an associate editor for clinical gastroenterology and hepatology. We're so glad you're here today, Evan. I would also love to introduce Mary Jo Strobel, the Executive Director of American Partnership for Eosinophilic Disorders, or APFED for short. She is joining us today for part of today's program and has over 27 years of professional experience in patient advocacy for allergic conditions and has served as APFED's Executive Director since 2012. We are truly honored she is here today. She has a broad background in patient education, awareness campaigns, and research in addition to her achievements in advocacy. Ms. Strobel has educated members of the U.S. Congress to encourage federal funding for research for eosinophilic funding and associated diseases and encourage their support for legislation for insurance reimbursement of medical foods and step therapy reform. Very important topics there. She was recently involved in the development and publication of a global patient charter to inspire policymakers and healthcare decision makers to reform healthcare practices for people living with eosinophil-affiliated diseases and has educated managed care and payer professionals about the clinical and economic burden of EOE, current and emerging treatments, and the importance of early diagnosis and multidisciplinary care. So we have a stellar here today stellar team here today for you guys, and we are so excited they are here. These are our disclosures. And again, a little bit about life with EOE. The Asthma and Allergy Foundation of America and the American Partnership for Eosinophilic Disorders conducted a multi-component cross-sectional needs assessment study for EOE. The study aimed to understand the patient journey of EOE as well as healthcare providers' awareness of and practice around EOE. We also look to understand the challenges and barriers in the timely diagnosis, treatments, and access to resources. Results from the study are published in a report titled Life with EOE, the Patient Experience and Opportunities to Improve Care in the U.S. This webinar is based off of the Life with EOE report and its findings, and we hope you find the support, resources here today that you can take with you. Most of all, we hope you find community here today. So with that, let's dive into a little bit more about learning about eosinophilic esophagitis. Dr. Dellon, can you please first tell us what is an eosinophil?
Of course. Thank you so much, Stacy, and it's a real pleasure to be here and talk with you all. So when we talk about eosinophilic esophagitis and other eosinophil GI diseases, it makes sense to start with what an eosinophil is. And this is a kind of white blood cell that's normal in everybody's body. They're found in the blood in low levels, and normally they're found in the stomach, small bowel, and colon. And like all white blood cells, they fight infections, and they're probably in the lower GI tract to prevent parasite infections. However, we never see them in the esophagus, and when they're there, it's thought to be abnormal. Eosinophils, in addition to fighting infections, have a response to allergy conditions. And so you would see them in the lungs in asthma or in the skin in eczema. And in many cases, when they're in the esophagus, it's due to an allergy in the esophagus, which is eosinophilic esophagitis. So eosinophilic esophagitis, we abbreviated EOE for ease of saying, but you can see how to sound it out there, is a chronic allergic and inflammatory condition of the esophagus. It is something that doesn't have a cure, but we're going to talk about a number of treatments that can manage it. And when eosinophils are in the esophagus, they tend to cause a lot of inflammation, swelling, and ultimately scar tissue. And that causes the disease and leads to a lot of the symptoms that we have with the condition. So this is a table that shows many of the symptoms for EOE, and there's a couple important points here. First of all, the symptoms are all what we would call nonspecific, and what that means is that many medical conditions can cause these kind of symptoms. So just the symptoms themselves can give you a clue that it might be EOE, but they're not diagnostic of themselves. And the second main point is that symptoms differ by age of the patient. So in infants, you have symptoms such as maybe failure to thrive or poor growth. Maybe it's poor appetite, difficulty feeding, or failure to progress to different foods. As kids get older, they may have nausea and vomiting. They may have abdominal pain. They may have heartburn or regurgitation, or they may actually have a sensation that food is getting stuck in the esophagus. And then when you get to adolescents and adults, trouble swallowing, which the medical term for that is dysphagia, is really the most common symptom. And it may be a sense of food going down slowly, food getting stuck, an impaction where food gets stuck in the esophagus and doesn't come up or down, or it may be other things where people end up feeling difficulty swallowing pills or having to change their diet to minimize these kind of symptoms. And then people can have chest pain and heartburn as well, but it's not heartburn from reflux, it's actually heartburn from EOE. Now, besides the symptoms, we can see a number of complications with EOE. Of course, again, in little children, if they're not eating well, they can have malnutrition. But over time, we think that all the inflammation in the esophagus will cause scar tissue and then narrowing of the esophagus. And then you could get, and when that happens, that's a complication called a stricture. And you can also have a diffusely narrow esophagus, so it's almost like trying to swallow through a straw. Then if food gets stuck and doesn't get up or down, that's a food impaction. And if that lasts more than a half hour to an hour, it's really time to get to the emergency room. And people may need an endoscopy to remove that food. And then in sort of the worst case situation, if the food injures the esophagus when it's impacted, the esophagus can perforate, which can mean getting a hole or rupturing, which can be a very serious complication. And then, as you might imagine, all of these symptoms can impact mental health adversely, and we'll talk about that a little bit later in the webinar. A lot of people ask how common is EOE, and there was the idea, which was correct for many years, that EOE is a rare disease. And in fact, it's also a young disease. We really only have known about it for about 30 years in its current form. And initially, it was so uncommon that if someone had it, many doctors hadn't heard of the condition, and it could be something in our literature where we would report a case, and it was that uncommon. But what we've seen over the last 30 years is a complete increase in the number of people who have EOE, and it's no longer really considered a rare disease. So these are some data from a very recent study looking in the United States, just asking the question, how common is EOE? And the answer is it's about 1 in 700 now. And so that adds up to about 500,000 people, at least in the US, with known EOE. The graphs show that over about 14, 15 years, you can see this continuing increase, and there's no reason to think that increase isn't going to continue. And the graph on the right shows you that it tends to be more common in males and females. Those are the blue bars versus the red bars. But you can see sort of a peak in commonness in children that are actually adolescents, 15 to 19 years of age. And the highest peak overall is actually in those who are 40 to 44 years old. And so it's even more common than 1 in 700 in those patient groups. So this is something that I think people with EOE are going to be encountering more patients like themselves, and providers are going to be seeing more and more people who do have EOE. Let's turn now to the approach to diagnosing EOE, and this is pretty well set out. One of the biggest problems with delayed diagnosis is really a lack of awareness or even adapting to symptoms of EOE. I think at this point, if many people come to a doctor, whether it's an internist or a GI doctor or an allergist, and report some of these symptoms, that will start the diagnostic process, but it requires that step of getting to the doctor, and particularly with the symptoms of trouble swallowing, many people don't realize that this is a symptom, and it's really not normal to feel food get stuck or go down slowly. Many times people may rationalize, oh, I just took a big bite, or oh, that piece of meat was overcooked, or I was just eating too quickly and talking. But it really shouldn't happen. And so if that's a symptom that's happening, you got to go get it checked out, and that will help decrease the delay in diagnosis and may decrease complications that are associated with EOE as well, including strictures. This is our first example of information from the Life with EOE study, and it was asking patients what are their challenges with diagnosis, and it gives us a sense of why it may be so hard to get a diagnosis. And we know that it takes a long time. On average in kids, it's at least 2 to 3 years, sometimes up to 5 years from symptom onset. And in adults, it can be between 5 and 10 years before a diagnosis is made. Now, part of that, again, is the time it takes to get into the system and to realize you're having symptoms. But even with kids who are having symptoms, some of the reasons for the delays is because they are originally misdiagnosed. And that happens because those symptoms, like I said, are nonspecific. They can be seen in other conditions, including conditions that are more common than EOE. There are not that many people who focus on EOE and eosinophilic GI diseases, and so it can be hard to find a specialist in certain areas, and it can take a long time to get referred, and then it can be hard to get the necessary testing. And we'll go through endoscopies, but that's needed for diagnosis. And so this is just some of the reasons why it can be challenging to get a diagnosis in place. You can see here some of the things that EOE can commonly be misdiagnosed for. So it's not uncommon for people to be told they have anxiety with eating, and the anxiety is causing their food swallowing difficulties or eating related symptoms. Little kids may just be called, oh, that's normal, they're a picky eater, don't worry about it. It may be food intolerances, but the most common one really is in the middle here, GERD. And that's gastroesophageal reflux disease, often called acid reflux. And this can cause trouble swallowing, heartburn, chest pain, sometimes stomach discomfort. It can cause symptoms of regurgitation of food coming up. And so it's way more common. About a quarter to a third of people in the US have GERD. So instead of 1 in 700, it might be 1 in 3 or 1 in 4. And so many times some of the EOE symptoms can be attributed to GERD, and that can lead to delays in diagnosis as well. To formally approach EOE diagnoses, it's important to understand that it just can't be done by symptoms alone. Like I said, there's many things that can cause symptoms of trouble swallowing, of poor growth, of regurgitation, of food sticking. So ultimately, to get diagnosed, the pathway does run through a gastroenterologist like myself, where an upper endoscopy is performed to actually confirm the diagnosis and, equally importantly, make sure there aren't other diagnoses that are explaining the symptoms. So this is what an endoscopy is, if you're not familiar with it. It's a procedure where you're asleep, and a gastroenterologist will, working usually with an anesthesiologist. Once you're sleeping and comfortable, we have an endoscope. This is the schematic there, the black scope. It's basically a long tube with a light and camera on the end, and it goes into the mouth, and we can maneuver it down the esophagus and actually into the stomach and first part of the small intestine. And the picture on the right is what a normal esophagus would look like. These are very high resolution cameras, and so we can really see a lot of detail. And here in a normal esophagus, it's smooth, it's wide open, and really the only thing that you see are those little fine red lines. Those are the normal blood vessels in the esophagus. And remember that appearance because here on the next slide, we're going to go through what it looks like with EOE. So these are endoscopic findings in EOE. And when we see findings of EOE, we use something called the EOE Endoscopic Reference Score, or EREFS, to categorize five findings. And so the first one is edema. That's the medical term for swelling. And in all 5 of these pictures here, you can see edema. There's none of that normal blood vessel pattern. Everything is pale and swollen. The next finding is rings, and particularly in the bottom left and bottom right panel, you can see those clear rings in the esophagus. That's some scar tissue generally. They're pretty prominent in the bottom left and bottom right. They're very subtle but present in that top middle panel. Then you can see furrows. These are these train tracking lines, particularly, actually they're in all the panels. We can see a nice example in that middle panel where they go up and down the length of the esophagus. You can see exudates. Those are those white spots, particularly in the top right panel. And then you can see a stricture. And in the bottom left, you can see where those rings get narrow down in that darker area. And that's a stricture. That's a narrowing of the esophagus. And so this is something that the endoscopist is going to look for. They're going to hopefully put this in the report. And these are things we can follow because our goal is to make these inflamed and scarred esophagus pictures look like the normal esophagus that I showed you on the prior slide. So we have a formal diagnostic process here for making the diagnosis. And what it requires is 3 steps. It requires having the right symptoms, getting an endoscopy with a biopsy. So we take little pieces of the esophagus lining, just a millimeter or 2, and those are looked at under the microscope by a pathologist. And if they see at least 15 eosinophils, so 15 of those allergy cells under the microscope, you can consider the diagnosis of EOE. Now, before you can make the diagnosis, your doctor has to really go through and make sure nothing else like GERD, irritation from medications, other allergic reactions, systemic conditions like Crohn's disease, infections, other kind of autoimmune processes, make sure those aren't going on and affecting the esophagus. And then when that's pretty clear that those aren't at play, you can make a formal diagnosis of EOE. And there's things that we do that increase our likelihood of EOE. So if a patient has a lot of allergic conditions, has someone else in the family with EOE, that makes us suspicious. if people are doing a lot of adjusting of how they eat, eating slowly, drinking fluid after every bite, avoiding foods that stick, being the last one at the table because they're eating so slowly, that can suggest to us that EOE might be at play as well. And so those are some of the things that we think about in the clinical pathway. But again, once you get into that algorithm, it's pretty straightforward, but there's a lot of ways that this pathway slide shows you that you may end up with getting that endoscopy at that diagnostic box in the middle. So, someone may go to their primary care doctor, their PCP, say, I'm having trouble swallowing symptoms, and get referred to a GI. Same thing at an allergist may recognize, oh, you have a lot of allergy conditions, you have some GI symptoms, we better get you scoped. Similarly, you may start at a GI doctor. Sometimes people actually will start at an ENT doctor. They feel something sticking and they're like, oh, there's something wrong with my throat. I'm going to go to an ear, nose, and throat doctor. And then they get referred for the scope. And finally, someone may come to the emergency room with a food impaction and then ultimately get to the GI doctor. But if you start anywhere but the GI, that's a step that requires a referral and a wait. And then after diagnosis, often GI doctors and allergists work in collaboration to optimize management. And then depending on who you are as a patient and what kind of treatment you get, you might work with a dietitian or a nutritionist. You might need a swallowing specialist or a speech therapist. You might need a psychologist or a psychiatrist to help with mental health or occupational therapists. So there's a lot of other ancillary team members who may be brought into the care pathway.
Dr. Dellon, it seems like that pathway to care is very meticulous and there's so many complexities. I can imagine if I was going through that process, it would be very exhausting. Is there someone that can help navigate that path for you? Or do you see patients that come into your office that kind of do it by trial and error? If this physician doesn't work or this healthcare provider doesn't work, they move on to the next. Can you talk a little bit about that?
Yeah, unfortunately, in most practices, there's not really a navigator that helps with this process. And, for instance, in our practice, we don't have access to a social worker in the outpatient setting. And so it really does rely on patients and families themselves to be advocates, to know that, if there's symptoms that are going on that aren't being adequately addressed, to seek a second opinion. Um, and if something seems like one condition, but the treatments for that condition aren't working, it's to revisit, is the initial diagnosis right? Could it be something else like EOE that's going on? And then ultimately understanding for EOE, it's got to go through an endoscopy. It can't be diagnosed anywhere else. So ultimately asking for a referral to a GI doctor is the way to get that endoscopy.
Thank you so much. I also wonder, is there a patient experience that you would like to share that you are familiar with that might resonate with our audience, if you
Yeah,
feel
yeah.
comfortable sharing?
Yeah, so I have a patient who I've seen for many years who's a young woman, and she originally had some trouble swallowing issues, and first attribute it just to the kind of factors that I mentioned before. Oh, it's nothing. I'm just eating too fast. I should slow down. Oh, that food was overcooked. And then, the symptoms kept getting worse and worse. And, people continued to tell, oh, you're just eating too quickly. Stop talking while you're eating. You must be anxious about things. And so she had attributed to anxiety for a while, as did some of her doctors. Then, she had a episode where she thought she had an allergic reaction. She was eating something, a bite of a sandwich, and felt tightness and trouble breathing and spasms in her upper chest, and thought she was having an allergic reaction to the food. But then it was like, well, it didn't seem like an allergic reaction because there wasn't a rash, it wasn't anaphylaxis. And so it went on and on like this for a number of years with no clear idea of what was going on. And ultimately, an astute allergist in a second opinion said, that sounds like maybe food is sticking, not an actual allergy reaction. You should go see Dr. Dellon. And so, I saw her, and at that point, she had maybe had 8 or 10 years of symptoms, ever since she was in maybe elementary school. And when I did the endoscopy, what I found was very severe EOE, where not only was there a lot of active swelling and inflammation, but her whole esophagus was like a straw, and in particular, it was very, very narrow with scar tissue at the top. So it wasn't anxiety. Obviously, she became anxious of having these symptoms and worrying about the symptoms, but that wasn't the cause of the symptoms. It wasn't reflux. It wasn't her eating problems. It was that she had scar tissue blocking most of the opening of the esophagus. And so I was able to ultimately get her treated and over time be able to stretch the esophagus. So now she's doing well. She can eat normally, and is feeling much better. But, had she been able to say, okay, it's not normal for food to stick like this, it's not anything I'm doing that's wrong, you know, and then essentially get to the GI doctor early, it could have been a much smoother diagnostic process for her. Okay, so yeah, so that's a good segue into talking about treatments now. Once you've gotten the diagnosis, how do we do treatments? And, there are a number of treatments. We have good treatments, both medical and dietary. And this is some of the medical therapies that are available. We're going to talk about each of these in more detail so you can see this table, sort of for reference. But the things we're going to talk about are proton pump inhibitors, which are traditionally antacid medicines, but have a different way they work in EOE. These are off-label for EOE, but readily available. You can have medicines like topical steroids, and the idea here is that these are swallowed to coat the esophagus. I often make the analogy of like rubbing a cortisone type of treatment onto a bug bite. If we can apply that to the esophagus, it takes away redness and inflammation. We have one that's budesonide that's approved, and we have off-label ones, fluticasone, that can be used as well. And then finally, a biologic called dupilumab is also approved for EOE, and that's an injectable medicine. So we'll talk about some of the details of each of these in turn now. So proton pump inhibitors, again, these are going to be your typical antacid medications. A lot of them are available over the counter. Some of them like omeprazole, esomeprazole, lansoprazole, and they're very, very commonly used for reflux. Now, for EOE, it turns out that they work almost as an anti-allergy type of medicine. They actually block some chemicals that bring the eosinophils into the esophagus. So when we use them for EOE, it's specifically not for reflux. They tend to be at a higher dose than we use for reflux, and they tend to be longer courses. And so these, because they're readily available and are effective maybe about 40% of the time overall, and relatively inexpensive, are often first-line treatments for those people who want to try a medication. And in general, have a very, very good safety profile. There's been a lot of publicity in the press in the last 5 years or so about many possible side effects from PPIs. But in general, those have all been debunked as theoretic or actually not risks of PPIs. And so, the PPIs do not really cause nutritional deficiencies, bone fractures, heart problems, dementia, many of those things that you talk about. And so they're quite safe. And for an initial course of about 3 months, there's no problem and no risk at all. So if people have a good response for this, the benefits strongly outweigh the risks of using these medicines. So the next class are going to be the topical steroids. And this is what again, swallowing a topical coating medication in the esophagus to decrease inflammation. Now, on the FDA-approved side, we have budesonide oral suspension. That's also called Eohilia. This is a premixed suspension that comes in little dose packs, not a vial like this. This is what you might get from like a compounding pharmacy. But they come in little dose packages, and it's approved for 12 weeks initially in people with EOE ages 11 and older. You just shake the medication, open it up, swallow it, it coats the esophagus. You can use it initially for the approval as twice a day. And then there are strong data that you can continue using this long term. Now, if you can't get that or have access to that, we can use what I generally call the home brews. So here you're going to adapt an asthma medication. So you might take a liquid budesonide that would be used in a nebulizer machine, or you might take fluticasone from an asthma puffer. And you're going to either mix the liquid into like a syrup with honey and swallow that, or you're going to puff the inhaler into your mouth during a breath hold and then swallow that. And that gets the medication into the esophagus. Now, even though these are steroids, these are anti-inflammatory steroids, they're low doses, and very little of it is actually absorbed into the body. So they have a very good safety profile. And we do not see typical steroid side effects like problems with bones, diabetes, problems with eyesight, weird infections, that kind of stuff. These are generally well tolerated. Maybe 1% of people might get thrush in their mouth, and about 5% might get thrush in their esophagus, and that's readily treatable. So again, initially we would use these for about 12 weeks, do another endoscopy and see how it's working, and then talk about maybe lowering the dose for longer term use. Now, biologics are a different kind of class of medication. These are injectable, and they're generally proteins, many times antibodies, that target specific factors that cause disease. From the standpoint of EOE, dupilumab, also called Dupixent, has been approved for EOE in pretty much everybody aged 1 year or older, or at least 33 pounds. And dupilumab specifically blocks some of the allergic factors that cause EOE and other allergic conditions like asthma and eczema and allergic nasal polyps. This is why it's approved across many allergic diseases. It comes as a prefilled syringe or an auto-injector that's used weekly in adolescents and adults. And if in people weighing under 40 kilos, it's every other week. In general, this is also very well tolerated. It's not an immune suppressant. The main side effects are actually injection site discomfort and reactions. Rarely you can have headaches or joint pains. Eye inflammation is rarely seen with EOE. And similarly for like herpes infections or cold sore flares, it can happen, but it's pretty rare. So this is remarkably well tolerated for a biologic medication, as you could guess, since it actually is officially approved for babies 1 year and older. So the last treatment option is not a medicine at all, but it's dietary elimination. And the idea here is that we think in most people, nearly all people, EOE is a food allergy driven condition. But it's not the typical eat a peanut and go into shock immediate kind of food allergy. It's a much more delayed food allergy. And so if you could theoretically know what the food triggers are and eliminate those, it would control the disease. The problem is that our current allergy tests that an allergist might do are not accurate at all for EOE. So we no longer recommend that testing be done to direct what foods to remove. Instead, we remove the most common foods that cause EOE, in particular milk and wheat, and sometimes egg, soy, all kinds of nuts, and all kinds of seafood. And there's different kinds of versions of this diet, some less restrictive, some more restrictive, but it's a very good option for people who want to not be on medications, try to find out what the food triggers are, and have the ability and motivation to stay on a restrictive diet long term. The last treatment is esophageal dilation, which is stretching the esophagus. And this is an adjunct treatment that's used in parallel with any other treatment that you have. All those other treatments, the diet and the medicines, are what I would call anti-inflammatory. So they're getting rid of the allergy inflammation, but they may not get rid of any scar tissue that is there. And so that's where dilation comes in. This just stretches open the esophagus if there's scar tissue. And this is done during an endoscopy when you're asleep. And the schematic is one of the tools we have, which is a balloon. We can put that balloon in a collapsed form down the esophagus through the scope, put it across an area of scar tissue that's narrowed, open it up, and that can gently stretch the esophagus. Many people will have discomfort for a few days after the procedure, and that's normal. Depending on how narrow the esophagus is, you might need several dilations to get the esophagus open enough. But the large majority of people will have a pretty quick response of trouble swallowing symptoms if esophageal dilation is performed. So this is something your doctors may recommend in addition to the other treatments. So in addition to those standard treatments, there are a number of emerging therapies as well, meaning new treatments that are under study. And these are some additional data from the Life with EOE trial, and just asking about how aware people are of these emerging therapies. And the top bar looks at healthcare providers, and the lower bar looks at patients and caregivers. And so there's some knowledge gap here where many patients and caregivers were not aware that there's some new treatments being developed for EOE. And the good news though is that the providers were more familiar with this and can communicate this to patients in the appropriate setting who might be ready for a trial or ready to hear about a new kind of treatment. And this is an example of some of the different kinds of treatments. So the first two, tezepelumab and sulricatug, these are both biologics. They're injectable medications. They're targeting another allergy factor that's different from the one that dupilumab targets. And those are in clinical trials right now. Barzolvolimab is also a biologic. It's an injectable, but this targets a different kind of allergy cell. It targets the mast cell. And mast cells are very involved in EOE, but this is the first time we're looking at a therapy that gets rid of them. And it'll be really interesting to see whether this works in EOE or not. There's a small molecule, meaning not a biologic, so a usual kind of molecule that makes up a drug called 1104. And this is really interesting in that it may help people achieve immune tolerance. What does that mean? That means if you're allergic to something, that means your immune system is recognizing it as foreign and reacting to it. This medicine may help your immune system understand not to have that adverse reaction to that particular allergen. So very promising in early stage studies. And then for the topical steroids, there's a few others that are being studied. Let's move on now to management support and some other resources. So it's important to work with your provider to develop a treatment plan. And so you may have a lot of questions, and it's a perfect thing, to talk with your provider about. And so asking your provider these questions can really help, I think, optimize your plan and also explain your priorities to the doctor or other healthcare provider about what your preferences are. So, understanding if your symptoms are controlled or uncontrolled, understanding side effects of medications, including whether things that you may come up in your own, internet searches are things to worry about or not, whether you need how frequently you should be having follow-up visits and endoscopies when you're under good control and continuing the treatment. Are there limitations to your activities? And then as you're going through developing a plan, it's important for your providers to know the symptoms that bother you the most. And that way they can be targeted. And then the symptoms also, if you're treating EOE, only symptoms related to EOE could be expected to get better. If there's other allergic conditions, that's really good to go through because that may open up other treatment options. And if you have questions about the best way to do treatments, go ahead and bring those to your doctor. So these are questions that patients frequently ask me, and I'm always happy to have patients who are well informed and ask questions. The management, as you saw with a lot of the options, can be pretty challenging. And it's up to you and your doctor to kind of talk through those options and decide which approach is going to be the best one for you. The diet itself can be challenging just because of how restricted those diets can be. And if you're on a diet and having trouble, you need to let your provider know that maybe it's not the best option for you. Maybe you need to change tacks, or maybe you need extra help with a dietitian or nutritionist. And other challenges are about if you're on medications, there's a large financial cost of some of the treatments. There's the cost of seeing the specialists, getting an endoscopy, having insurances cover all that stuff. And if you're doing diet, it's expensive to get sort of specialty foods that may be allergen free. So all of these are things to potentially expect and anticipate, and then you can address these challenges with your providers and with your support systems. Because EOE is chronic, monitoring your symptoms and your EOE long term is really important. So you can keep a symptom diary to understand, what symptoms are happening and how frequent are they getting better, how do they relate to other allergies and treatments. You help your doctor understand, is the diet treatment the right one for you? What treatments are working? And again, how frequently are you going to be seeing your doctor in clinic, how long are you going to be following up, and what the endoscopy plan is going to look like. In addition to all of the medical things, it is important that to realize that EOE can have a substantial impact on your quality of life. And so I'd like to bring Mary Jo Strobel back in to the discussion here and get her take on this from the patient advocate standpoint.
Thank you so much, Dr. Dellon, for such a comprehensive overview. So EOE affects far more than the esophagus. The impact often extends into every area of life, physically, emotionally, socially, and financially. For many patients and families, the path to diagnosis is long and frustrating. Symptoms may not be readily recognized by people experiencing them, and when medical care is finally sought, a person may then experience dismissal of symptoms by their doctor, multiple clinical visits with different specialists, and misdiagnoses. And after a diagnosis, the emotional toll can be heavy. People often describe a sense of loss and grieving, the changes in how they eat, socialize, and plan their daily lives. Findings from the Life with EOE study underscore this. Patients report stress, anxiety, isolation, and even depression, often tied to ongoing dietary restrictions and the unpredictable nature of the disease. In addition to physical and emotional health, the impact of EOE can extend into other areas of life, like social activities, especially around meals, and travel, which can be more stressful, particularly if a person is navigating dietary restrictions. The financial burden of ongoing clinical care for a chronic condition like EOE, specialty foods and medications can have significant impact. Beyond that, EOE affects school or work attendance and performance, reduce self-confidence, and even shape decisions around family planning and relationships. This data comes from the Life with EOE survey of patients and caregivers, which asks, what are the biggest challenges in managing EOE? The top response by far was diet management, with 64% of respondents indicating it was a major difficulty. For many, managing a restricted diet is not only emotionally and socially isolating, but it's also time-consuming and financially burdensome. Next, 38% said they struggle with the effectiveness of care or treatment, and 28% pointed to the cost of care as a major challenge. Other key concerns included a lack of information about EOE, conflicting guidance, limited access to specialists, and not having easy to understand resources. It's also important to note that lack of peer support and difficulty scheduling appointments were each cited at 12% of respondents. Reminders that the patient experience goes beyond medical care alone. Stacy, I'll hand things back to you to summarize the key pieces of information in the Life with EOE.
Thank you so much, Mary Jo, and thank you also, Dr. Dellon, as well, for that incredible bird's eye overview of EOE. I know I have learned so much already, and we have Mary Jo, I'm going to ask you to come back in just a little bit, so don't go too far. We have some great resources and support services available for everyone out there as well. But very quickly to recap, the key findings of this study of life with EOE found that a delayed diagnosis is very common. And as Dr. Dellon said earlier, symptoms are not well understood or even recognized as it progresses. And people with EOE need multidisciplinary care. Remember that pathway to care guide and that infographic that we saw that was very complex, and a lot of times we need help navigating that system, and that's where your supports can come in at your healthcare provider's office, or with your dietitian, or with your psychologist, or with your supports there. So those are very important. We also learned that there are limited options available for approved treatments, but there are many coming down the pipeline. So following a treatment plan, it might be challenging, and especially those dietary therapies. We also learned that EOE can greatly affect your social and emotional well-being. And that's why it's also so important to have that community and to have those supports and those resources ready to go for when you need them, because people need more support and we need more resources. So with a final note, I'm going to ask Mary Jo to come back and talk a little bit more about APFED and share their great resources and supports and programs. So Mary Jo, I'm going to hand it back over to you.
Thank you so much for the opportunity, Stacey. I wanted to briefly introduce APFED to viewers who might not be familiar with us. We were founded in 2001. We are a nonprofit organization dedicated to preventing and curing eosinophil-associated diseases while enhancing the quality of life for patients and families. APFED achieves this by passionately embracing, supporting, and advancing education, awareness, research, advocacy, and support initiatives for those affected. The first resource I'd like to highlight for those wishing to do a deeper dive about EOE and about eosinophil-associated is the APFED website, apfed.org. It's an information and resource-rich website. It's devoted to these conditions and can help you with everything from navigating a new diagnosis to staying current on treatment options and research. On the site, you'll find easy to understand disease overviews and management tips, downloadable resources and guides for patients and caregivers, including our EOE toolkit, details on clinical trials and emerging therapies, and ways to connect with others who live with EOE through our online community, our virtual support groups, and events. So whether you're newly diagnosed or an EOE veteran or supporting a loved one with EOE, APFED.org has the tools and resources that you need all in one place. We also offer a range of free webinars and podcasts designed to educate, support, and connect our community. Our webinars focus on specific topics, including latest research, treatment updates, and ways to manage symptoms, presented by leading experts in the field. Our podcast series features real stories and expert interviews and practical tips for navigating life with EOE, from diagnosis to treatment and daily care. So you can explore upcoming and past episodes at apfed.org/webinars and apfed.org/podcast. Finally, you can access recordings from APFED's annual Summer Patient Education Conference, which is an event that brings together people affected by eosinophil-associated diseases. Our 2025 conference will be recorded live from Raleigh-Durham, June 26th through 28th, and will feature expert presentations, including from Dr. Dellon and his colleagues. Our virtual conference platform remains open year-round, so if you're viewing this webinar after June, you can still register and access the sessions at your convenience. You can visit apfed.org/conference for details. Zulema, I'll turn it over to you now.
Thank you so much, Mary Jo, for sharing information about those wonderful resources. And now I'm excited to share about AAFA resources. EOE can be a complex condition to manage, and so AAFA and our food allergy division, the Kids with Food Allergies, have created a guide called Your Guide to Managing Eosinophilic Esophagitis. And this guide covers what EOE is, signs and symptoms in infants, children, and adults, how it is diagnosed and treated, ways to manage the impact of EOE on your quality of life, and how to find support. You can find this guide at kidswithfoodallergies.org/EOE. I also want to take a moment to highlight our online patient support communities. We have two. One is for adults with allergic conditions and asthma, which is available at AAFA.org/join. And our second one is available at kidswithfoodallergies.org/join. It's for parents and caregivers managing their children's food allergies and EOE. Adults are welcome to join as well. We also have our Ask the Allergist service, which is a free service provided by AAFA, and you can send in your questions to be answered by one of our allergists. Please note, this program, we can't offer medical advice or guidance, but we offer information that can help you understand your condition and provide resources for you. And then we also have our support center where we can help with patient assistance, health insurance questions, and more. Lastly, I want to highlight additional resources that can help you manage EOE. On the Kids with Food Allergies website, we have over 1,500 allergy-friendly recipes, and we have a directory of new allergy-friendly food finds. To help you navigate dining out or shopping for foods, we have pages on major allergens that include ingredient lists and chef cards. For those who are using an elemental formula or an amino acid diet, we have a resource on medical formulas. And then lastly, we have a school zone to help you with school forms and accommodations. So we encourage you to check out all of those amazing resources. And with that, Stacey, I'll hand it back to you.
Absolutely. Thank you so much to everyone here today. Again, thank you to Dr. Evan Dellon for joining us today for your informative and very comprehensive discussion. And thank you so much to Mary Jo. Wow, what an honor it is to have you here from APFED to come and join us today and talk about your community and the support and the great work that you do over at APFED. And we encourage anyone joining us for this webinar today to please go check out those resources, get in touch, get in contact, and really find that community to help you thrive, because that's what we want. And I'd love to really thank Regeneron and Sanofi for their support of this educational program. All content was developed independently by AAFA. As a reminder, please complete the survey at the end of this program so we can learn more about you and your experience, which will help us plan for future programming. Again, my name is Stacey. Thank you so much for joining us. Have a great day.